So just a little bit about our speakers. Stephen Berkow, he's the head of value-based care market strategy at InterSystems. He brings more than 2 decades of leadership across both health plans and provider organizations. He launched a SaaS business at Optum Insight, led best practice programs for health systems at the advisory board, and directed Press Ganey's clinical engagement solutions. At InterSystem, Stephen guides strategy to help organizations turn disparate clinical data into actionable intelligence. Technology now supporting health data for over 220 million people in the US. He holds a JD from Harvard Law School and began his career advocating for safety net providers in New York City. Welcome, Stephen. And Julie Smith, head of global healthcare market strategy at InterSystems, is a seasoned leader in clinical informatics, product strategy, and healthcare delivery. With more than 15 years' experience, she shapes global product development for providers, health plans, and health information exchanges, including major government-sponsored entities. Her background as an emergency room nurse, particularly serving safety net populations and disaster relief efforts, grounds her work in practical clinical insight. Welcome, Julie. And I'll now turn it over to Stephen to start the presentation.
Thanks, Charlie. And I just want to thank everybody on the line for finding an hour in your hectic Monday to explore with us how to leverage clinical data to modernize risk adjustment. I think the slide on the screen does a pretty good job of quantifying the pickle we all find ourselves in. Today, more than 6 in 10 Medicare Advantage enrollees had at least one chart review record. And in plain English, what this means is that pretty much most Medicare Advantage health plans are now chasing charts for a majority of their members. And the costs are pretty staggering. Click. You can see our high-tech click here. There we go. Obviously you have the direct costs, which most plans now place at $10 to $15 per chart, keeping in mind that sometimes you're pulling multiple charts for a single member. And then you've got to factor in the indirect costs as well. A lot of stuff talking about challenges with provider abrasion. Obviously, as somebody who ran engagement solutions for providers, something near and dear to my heart. But continuously banging on the provider door to ask for more and more charts, frustrating provider abrasion. And then there's also the value of this data for other applications, because all too often it's retrospective. It diminishes the value for other functions like care management. Now, it's still understandable kind of why chart chasing has ballooned or why we're in this pickle. I'm going to be using Medicare Advantage data here for a short while for the simple reason that it is one of the best national data sets we have available to us. And if you look at the pie on the left, you can see that if you just take two factors or two kind of pieces of that pie that are heavily dependent upon clinical documentation, you are already up to 20% of Medicare Advantage plan revenues. Now, again, today we're focusing on risk adjustment. So I'm going to go ahead and double click. Don't click on the big, don't click, go back on the bigger piece of that pie, which is risk adjustment. But before we kind of set sail here, I do want to re-anchor everybody in what is the purpose of risk adjustment. So I'm just reading here. Risk adjustment is used to estimate the cost to treat a patient in a given year based on the patient's specific health needs, so that providers are able to treat patients with different healthcare needs and not just healthier, less costly patients. And this is really important to always keep this in mind, because even with all the advances in value-based care, all the advances in preventative care, it is still really costly to take care of those more complex, those sicker patients or members. If you go to the next slide, you can see that recent estimates place this at $80 billion per year. And again, this is just for Medicare Advantage plans. This isn't including other sorts of situations where we're sharing risk. And So you really begin to understand why it's so important that we get this right. It's not just to ensure that we're going to have sufficient resources to take care of our more complex members. It's also to ensure that we're going to have significant reimbursement to the plan itself so the plan can be here tomorrow. And what you see on this scene is on the screen is a breakdown of that $80 billion. And right off the bat, if you take the first two pieces of that pie, you can draw a pretty direct line between chart review and getting the necessary dollars you need for risk adjustment. So $24 billion if you sum up the 19 and the $5 billion. And again, remember what we're talking about. Why have we gotten ourselves in this pickle? It's not by accident. It's very, very defensible. I do want to talk about the other kind of pieces of this pie, because the $24 billion is kind of retrospective. But going forward, we're going to get into it deeper. There's going to be more and more pressure to rely upon risk adjustment to actually ensure you're getting the revenues for the other pieces of the pie. The big blank piece is the claims, or for Medicare Advantage, actually the shadow claims, the 837s, pulling diagnoses out of that. Going forward, we're going to get into it. There's going to be more pressure to back those up with documentation in the clinical record. And same thing for the 10 billion HRA, the health risk assessment. Going forward, we're going to get into, there's a new linkage requirement. So again, it's going to be harder and harder to just document a diagnosis for risk adjustment based on an HRA alone. So just pulling back for a second, I think the question we all really need to start asking ourselves is whether the chart chasing that's been built up over time is sustainable going forward. Keeping in mind two things. Number one, most of the plans that I'm working with, they already feel like they're at a breaking point. In current course and speed, this is going to continue to spike upwards unless we rethink how we do this. On the screen is just a primer on Medicare Advantage risk adjustment, a super quick primer. This is going to be pretty basic for people on the line who oversee coding. So if you want to blank out for 1 minute, now's the time. This slide is really for people. I noticed that there's a lot of people on the line who are also from interoperability or IT. And I just want to be sure before we get into go further here that everybody has a certain foundation in terms of the key moving parts in terms of what happens with risk adjustment. So two key concepts. The first is everybody who is a Medicare Advantage member gets a risk adjustment factor or RAF score or multiplier every year. And it's explained right there. It's a numerical value used to estimate a patient's expected healthcare costs relative to an average beneficiary. So an average beneficiary is basically one. And it's calculated annually for each Medicare Advantage member based on their demographics. And here's the important part, documented diagnoses actually from the prior year. So it is a prospective member calculated based on documented diagnoses from the prior year and then used going forward to adjust what is the Medicare Advantage payment rate from the government to the plan. So then what the government does is they conduct what are called risk adjustment data validation, or more commonly RADV audits, to ensure that the information that is being submitted by the plans is accurate. So second bullet there, they're verifying that the diagnoses codes submitted are supported by appropriate documentation in provider medical records. So let me be clear, this is an audit. So every member gets a RAF score. Only a subset of members are subject to a RADV audit each year. On the left, just a couple of things I want to call out. 3 musts for a defensible RAF score. So 3 things that you're going to have to kind of check the box on if you're going to be on the right side of a RADV audit. Number 1, the submitted diagnosis codes must reflect conditions documented during a face-to-face encounter within the payment year. So again, underscoring very specifically a face-to-face encounter with, of course, the treating clinician. The documentation used to support that must meet what is commonly called in the industry the meet criteria. Now, let me be clear. This is not a CMS requirement. There's nothing in the regs that say meet criteria. It's just a mnemonic that the industry uses to ensure that you are complying with the requirements, which are monitoring M, evaluating E, assessing A, or treating the reported condition. So there has to be documentation that shows at least one of those. And then the last one's really important here. The chronic or permanent condition must be redocumented each year during patient encounters. And this starts to get into all too often why this doesn't show up in the shadow claim, because claims are often only submitted to something where the physician is saying, hey, I have something that's reimbursable here. And obviously, they're monitoring a lot of things that from when you have a complex or chronic condition for which there is no immediate claim. But again, in effect, you have to redocument all those factors that might merit risk adjustment every year. So let me be clear. What you're looking at here, this is my quick primer on the status quo, like today. And what I want to do on the next slide is start to roll it forward. And I mentioned that we put a lot of pins in things, that there's this increasing demand for clinical documentation. And I want to get into why on this slide. It's not really, or it's not due to changes in the RAF score. What's really driving this spike in demand for charts is changing in the RADV audit program. So the first one is audit frequency. Looking back historically, CMS did about 60 contracts per cycle. Going forward, CMS has announced, and by the way, this has already started this year. This isn't going forward next year. Already started this year, that they're going to audit all 550 contracts annually. And guess what? The active ingredient that they're counting on to enable them to do this is AI. The sample size. So click. So historically, they did about 35 enrollees per contract. Now they're doing up to 200 enrollees per contract, depending upon how many members or how many beneficiaries are in the contract. But if you start to put those two things together, think back to that, that other piece of the pie, the big piece of the pie of claims that were justifying a higher RAF score. So now it used to be that, okay, there were the relative number of audited members each year was relatively small. Plans were able to then request charts just for those members. Now we're moving to all contracts every year, up to 200 enrollees per contract. So more and more pressure for the plans to, in advance, ensure that they have the clinical documentation necessary to back up every claim should it be audited. The other thing going on here is cadence. So across time, CMS had fallen a little bit behind, or a lot of it behind, in terms of these annual audits, and we are really in catch-up mode. So instead of just doing it annually, they are launching kind of the next series of audits every 3 months. So that's already happening, and we're already seeing a spike in demand for chart chase. The last one is coming online next year, and going back, you used to were allowed to use unlinked chart reviews to back up your submission of a DX code, diagnosis code, that in effect would drive the HCC. And a lot of those came from health risk assessments. Going forward, starting next year, that's not going to be the case anymore. Any supplemental submission you do to the encounter record from CMS, it must be associated, or what's called linked, to an actual encounter with a physician. So yes, you can still do an HRA, and you can still surface a chronic condition, but you cannot use that going forward for risk adjustment unless you link it to an actually submitted claim that was face-to-face. So I know that was super fast, but I hope it was helpful. Again, pulling back, I hope you guys are beginning to see why this question is getting so critical. How can we start to rethink how we do chart chase? Because it's already a problem. it's set to uptick, and it got a number of our plans that we work with and ourselves thinking, wait, there's got to be a better way to do this with all the data liquidity we have with interoperability in the last year or so. And I'm going to hand it off to Julie to start answering that tough question.
Thanks, Stephen. So, I think what Stephen has said is really set it up to explain the problem at hand and the challenges we all face with getting this data available in a way that can be leveraged to accurately reflect the member population. And, one of the opportunities here is what you see on the screen. This is, part of the sort of format and code of a CCDA document for those of you who are familiar with these. These are clinical documents that are sent, that are episode-based, time-stamped, and auditable related to an encounter. And so one of the conversations that we have very frequently is around the idea of how do we address some of those challenges of the uptick in the audits, uptick in the need to ensure that all of that data is actually entered into the record in a reasonable turnaround time, given the shift in risk that has occurred in the industry. And CCDAs offer some of this because they're clinically based, so they're not delayed like claims data is. It supports both structured and unstructured documentation. And it's something that you very likely may already have in your environments. And I think that's really key because one of the things that we learn as a vendor at times is that we actually get the privilege of sharing with health plans that there may already be something in your ecosystem that can be leveraged. And CCDAs are a great example of that. And leveraging the power of the clinical data that's available is really something that we're seeing increasing across the industry because CCDAs may come in from a number of sources. You may be getting them from direct feeds from network providers. This may be via Epic Payer Platform or another entity. And they may come in from HIEs and other networks that you're members of. And we actually see a number of health plans getting them from data aggregators. And so across the board, we're seeing an increase in the availability of CCDA documentation that could potentially be leveraged for risk adjudication because it likely already sits in a clinical data repository. This is certainly true with some of the regulations that are out as well. And so there's just this increasing volume of clinical data that's now available that may be able to be tapped in order to address some of these risk challenges and needs. And so as this evolves, one of the things that we see is there's an opportunity for the entire workflow and processing to shift. And Stephen, I know you want to cover that here.
So I hope it's evident. I know we have some plans on the line who work with us, but we work with a number of plans. And again, this is my best effort to take a really complicated process and just reduce it to one slide. So on the screen, my best effort, imperfect, but my best effort to summarize what I would call the typical or dominant practice in terms of how we do chart-based risk adjustment. So this is our leaping off point from, but here's when we kind of start working with a plan, what we commonly see when we come in. So the process starts with historical claims analysis. And this is either the plan or their vendor going like literally years back in time, looking at all the different claims to identify a member who seems to be struggling with a chronic condition or an ongoing complication that would merit a higher RAF score going forward. And then from that historical analysis, they generate a suspect list. So it is literally a list of members, a list of suspects that the plan is thinking, wait, these are more complex patients. We're going to need more resources to take care of them going forward. And we need clinical documentation to support that so we can get the appropriate RAF scoring. Well, here we go. Now we've got these lists of people. We need that clinical documentation. So we start chasing charts. We start banging or calling, or ironically, sometimes it's calling a provider and saying, hey, do you have a chart on this person? Ironically, often what we get back is the CCDA. but we banged on their door to ask for these charts. Then the chart reviewer has to look at those charts for two things. One, to identify diagnostic codes to back up RAF scoring for people, to identify clinical documentation in the chart for diagnostic codes that were already submitted to CMS, as well as to identify diagnostic codes for members, I blew it again, to identify clinical documentation for members for which there was no diagnostic code submitted, and they want to go ahead and submit a supplemental claim. Then, of course, it's now really important going forward. All this information has to be captured and archived in such a way that if and when a member is subject to a RADV audit, that information is ready. It's not a situation, because these RADV audits can, historically, they can occur well after the clinical documentation. To use a highly technical term, the necessary clinical documentation is readily gettable. So it's easy to get through a RADV audit. So, I mean, it's a lot, and it's particularly a lot when you think about, we set all these filters in place, and increasingly, even with all these filters, we wind up having to bang on the door for the providers to ask for charts for over 50% of our members. Again, you get this feeling of the system is being overwhelmed. And what I want to do on the next slide is give you a sense of how we're evolving this process with leading plans. So the first thing we're going to do is we're going to change the role of the chart reviewer. So click. Hey, go ahead and click again. Yeah, so the first thing we're going to do is, instead of putting all that work on them to review the charts, we want to put them in a place where they're more of an approver. And in order to do that, obviously what we need to do is equip them with better decision support. And this starts all the way on the front end. Click. So big change here. Instead of doing that big historical claims analysis, this goes back to what Julie was talking about. Most plans are already getting a lot of the information they need, not necessarily for every member, but a lot of members and a growing number of members, the necessary information to back it up in terms of submitting a diagnostic code to justify a RAF score. They already have that information. And what we're saying is, look, you're already getting that information. So the first thing we should do is we should just go grab all that information, and we should pull out the relevant charts and diagnostic codes in that information just for the prior year, or the current year, actually, ideally, as it comes in, instead of looking way back in time. So great, now we have all this information. And then step two is leveraging AI to do a couple of things. So again, the first thing is we want to look for clinical documentation to support diagnostic codes that have already been submitted in the claims, and we want to be sure that we document it so it's readily available for a RADV audit. That, in effect, is use case one. Use case two, we also want to think about, wait a minute, are we capturing clinical documentations for diagnostic codes that aren't there yet? We want to be on the lookout for them so we can match them immediately and or submit a supplemental claim. I will go back. So I just want to be straightforward with everybody. Those, in terms of the leading plans we're working with, that's really what we're working with them. That's what we're really working on with them right now. There is kind of a third use case out there. It's a little farther out. And this is aspiration that all this information is going to be tagged and readily searchable. So not just the coder, but provider relations is better set up when they go talk with the providers to actually talk about whether it's by HCC code or specialist area. Hey, here's some things. Here's some opportunities where we could have a more accurate clinical record. But it's really these two big steps that we're working on to change the process. So one, we're not going to do this whole historical claims analysis and then pull all these charts. We're just going to start by grabbing the clinical data that most of the time, many of the plans that we're working with is already getting. And then we're going to deploy AI to identify the DX codes and supporting documentation to match that up. And I know, Julie, you want to talk a little bit more about how AI can work here.
Right, and one of the privileges we have, if you go on to that next slide, is that we do a lot with clinical data, and so we have the opportunity here to test out where in those CCDA documents, where in that clinical data repository the diagnosis may live, and combine it with the evidence, leveraging AI in a way that then can be substantiated. So one of the things that Stephen mentioned was, the fact that so much of the documentation on this has to be revalidated or re-entered on an annual basis, and it cannot just be the diagnosis code, right? You have to actually show the evidence of treatment and the addressability of it. And so one of the ways that AI has really been proven valuable is when you have diagnosis, say diagnosis A, in a CCDA, it can be linked up to evidence in one or two to then get a substantiated diagnosis prediction model. And one of the things that AI is very good at in this space is actually providing it with a confidence score as well, because we all know that humans need to be in this loop and need to have review and authority over the decisions here with the clinical data, but it actually does a lot of that underground legwork to put the pieces together in a way that can really accelerate workflows. And so based off those predictions and evaluations, it then provides a confidence score that a human can then review and validate or return in order to be able to move those forward. So ideally, this is not just a piece of the puzzle, but it actually informs the rest of the architecture in a way that can actually be accelerating for all of the workflows involved. Next slide, please. So when we think about this, right, I mean, one of the things that I said a little bit earlier and Stephen alluded to is the fact that CCDAs actually very often already exist in the environments that you work in. And CCDAs have not always been leveraged across all of the value props lines of business and workflows that have the opportunity to actually accelerate the work that you're involved in. And so as clinical data becomes a norm and a standard within your environments, when you have those feeds that actually come from all of those places, whether it's network providers, a payer platform, HIEs, whatever it may be, and in fact, from the internal systems that you work with, pulling it together for that unified repository with clean data is really where you can see that acceleration happen, not just in risk, which is what we're talking about today, but we actually see it crossing other use cases to say, how can I leverage this for quality? How can I leverage this for gaps? How can I leverage this for member engagement? Because it's such a rich repository in a way that has much more recent information that claims is just not always able to provide. And so we see this as another step in a pathway to really getting the value you're looking for when you already have some of this in your system. And it's just another step to leverage it further. Next slide. So when we think about all of the things we've talked about, what we actually sort of focused on was risk, particularly given the audit changes that we're seeing in the industry and the known fact of the cost of chart chase involved. And because there is a better way with clinical data being able to leverage that and AI on top of that, actually getting to the fact that it can accelerate and be more definitive in terms of finding the data needed for RAF scoring itself and for the audits to have that traceability involved that's necessary. All of this is part of that journey and pathway for getting the value out of the clinical data that you have in your system already and that will continue to be fed in. What we also learn is that as you do this across systems, we've certainly seen this at InterSystems in the provider space with some huge customers that you see on the screen, but you actually become sort of more intertwined with the larger health IT ecosystem in a way where things can be exchanged more seamlessly and leveraged more fully. And so that's one of the things that we want to highlight is that risk is one of those that affects your bottom line. It just does and has so much nuance to it. but there are ways to improve that process, leveraging some of the tooling in your system and some add-on capabilities in a way that really offers some opportunity in this space. I know we've covered a lot of things, and I'm wondering if there are some questions that may have come in the chat, or Charlie, if you have any other things to add.
I don't see any questions in the chat. So I'll start with some that I have, and then if anyone has any questions, just please pop them in the chat and we'll go from there. So Julie and Stephen, can this strategy still work in markets where there is limited or no participation in the local health information exchanges?
Yeah, sure. I mean, as a matter of fact, some of our early partners, they are in markets where there's no HIE. You have to have some clinical data, streams set up. But I know with a number of the Blues that there are a tremendous number of Blues who are already getting clinical data streams from, larger health systems within their areas and regions. And I will say that I'll say some of our early partners are pretty bullish on the value they're going to see, even though they have no HIE.
All right. How about how do you validate that the AI is applying CMS HCC logic correctly? What quality assurance processes should be in place for that?
So I'm happy to take that. I think, one of the things that we find across the board, this is certainly a use case where it applies. There are many, many others of where governance, auditability, traceability, human in the loop, all of those concepts are absolutely essential. That the clinical data that becomes available through a CCDA feed or from a number of sources still needs to be looked at within the broader, larger picture of the profile of this member and what this member has within their record, not just for this calendar year, but for prior calendar years, and being able to actually trace it through and back to see where data has changed, where it has been updated, what new information may come in across the board. And so what happens is that you need to actually have tooling in your system to be able to identify all of those steps in the process. And it absolutely requires that any of the rationale or logic involved in the system to say, I believe there's, if it's AI that's presenting to say, I believe this diagnosis goes with this evidence to go, and there are these HCC codes, that all needs to actually be traced back to the original source in a way that can be validated. That's the expectation that's going to be put on you for an audit. And so it's absolutely essential that the tools actually provide that visibility and that there's that human in there to review it, to validate it, to cross-check it, and make a final decision. That this is not an area that we would ever recommend some automation to the point of human exclusion or as a black box. Right, a black box is not sufficient in this space. We see a lot of black box tooling out there, and there are some use cases for it, but this is certainly not one of them. And so, making sure that all of that, and I tend to think of that in the bucket of governance, but it's really so much more than that, is available within the tools that you select yourselves.
Yeah, governance and auditing for sure. Okay. Real quickly, just a quick housekeeping thing. Lisa, I just want to make
So Charlie, you are frozen for me. I don't know if that's true for everyone.
So while we're waiting for Charlie to pop back in here, I just want to say to everybody on the line, obviously, we're very bullish on this. And we've walked into a lot of at least some of our early partners where it's really interesting to see that on the interoperability side, the information is there, and all too often the groups that lead risk adjustment aren't aware of what's in the CCDA, and then vice versa. The interoperability people know what they have, but they don't fully appreciate. Wait, I actually have a lot of the information that could eliminate the need for a large number of chart chases. So I know I'm just geeking out here, but if you're really intrigued by this stuff, we're actively looking for other people who want to build out this use case. So feel free to reach out to me or Julie. I see that we have like a general contact information for InterSystems, but it's not rocket science. I'm Stephen.Berkow@intersystems.com. We really think that there's a huge potential for a win-win-win here, and we've just got to stitch this together across our different organizations. So if this is something that your plan is really interested in or just wants to know more about, we are definitely looking for partners who want to co-develop with us.
Yeah,
And Stephen, I might just
has
tag on.
So I'm taking over for him, but go ahead, Julie.
Well, I was just going to tag on to what Stephen said and maybe clarify with him because I know we work so closely with so many of you. But if there is something that you found in the early engagements thus far around an approach you recommend in terms of rolling this out and getting engagement and buy-in from all of the stakeholders involved. I was going to ask you that, Stephen. I don't know if you have a thought.
No, I don't know if Lisa, you were going to step in. I know Charlie had shared with us he had some other questions.
I don't have those up, so I don't, and I'm not seeing any new ones in the chat.
So no problems. Just a way in there. And I know we're getting close to end, but I know that Stephen, when you've worked with a number of early adopters in this space, there's a question of sort of where to focus first. Is it about reducing and how to track it? Is it reducing chart volume? Is it getting a certain line of business up and running? Where do you recommend starting?
So personally, I recommend starting that. I think this is something. Let me try again here. I do a lot of stuff where I work with plans where I'm trying to do stuff where we have the plans in the room and we have the providers in the room, and the fact that I come from both sides of the equation, I'm helping to make that connection. Ironically, this is something that I think plans can and should unilaterally start. It goes back to what Julie said. Most of the people on the line, you're already ingesting. Your CDR should already be ingesting a significant number of clinical data streams. In these clinical data streams are usually a large number of CCDAs. It is the dominant thing. If you have an HIE that you're getting from an HIE, you're usually getting this. If you have any direct connections with providers. So I think this is one time where we don't have to start by getting provider buy-in. You can just start doing it. And I add, matter of fact, I recommend this. Try to do it. And then once it's up and running, instead of being another thing that you go to a provider as your network providers and say, hey, we'd like to do this, but we need your buy-in. Hey, we're doing this for you. I think the number one thing that you want to track, where hopefully you'll begin to see an impact pretty fast, is a reduction in the percentage of chart reviews requiring a chart pull. And the reason why I really emphasize that you have to track percent as opposed to total number, it goes back to what we were talking about. The total number of chart reviews is going up. So it is possible that the total number still of old school chart chases might go up, but they might fall from 60% of your members to 20%, which is, I think, going forward is going to be essential. Otherwise, we're going to be overwhelmed by this stuff. But I'd much rather, I always joke around with people like, when is the time to bring out the brass band to announce to your network providers while you're doing something? I think it's better that if we just do this, and then when we start to see it working, then we go share, hey, we've done this for you. Are you feeling an impact? Because I think this is one of the few things in the clinical data world where we don't need provider engagement to get going. Most of us are already getting this clinical data. I don't know, Julie, is that kind of like when we talk, is that the kind of stuff you were like
Exactly.
asking after? Yeah.
Yeah, and I definitely think there's this idea, right, of leverage what you have, and get the full value out of it. And I think there's great opportunity here.
Yeah, I mean, it's one of the things that when I'm talking to people that I struggle to see a reason not to do this, because it's not like, again, you have to go out and get this clinical data. Most of you are already getting your this clinical data, and you're going to get more and more of it. Just because of all the mandates or the Blues commitments that are being made. I mean, the wind is at your back that this pipe of clinical data is going to continue to grow. And it just seems such a missed opportunity if we're not using that to actually deal with one of the greatest and costliest irritants to everyone, which is going to become even more problematic going forward if we don't rethink how we do it.
Well, thank you so very much. And if anybody on the call has additional questions, you can email me or Charlie. Charlie is back. Hey, Charlie.
I'm back. But random reboot during the middle of the day. So, but I'll let you keep going because
yeah, we were finishing up. So I just wanted to thank Stephen and Julie and InterSystems. InterSystems has been a tremendous supporter and sponsor of our eSolutions Exchange Conference for many years. So we appreciate your insight and knowledge and time today. And again, if you have any additional questions, you can email Julie, Stephen, or if you have issues with their emails, shoot me an email. I know you get lots from me, and we will get those appropriate questions to InterSystems. Thank you so much.